Well, thank you everyone so much for coming today. I am Betsy. I work at the Traverse Area District Library in the reference department, and we do programming for everyone via in person right now and also on Zoom. So thank you those who came today. The people on Zoom, I want to let you know we're in a webinar style, so we can't see you, but if you do have questions, you can utilize your chat feature and we will answer your questions that way. Either Jen will in person or we can chat it back to you. So don't worry about that. And everyone else, you can just talk like normal or however Jen wants to do it. Today, we're gonna learn about hospice from Jen Campbell. So we'll just let her take over. Thank you.
Hey everybody, thank you so much for being here today, and to all the people on Zoom. I wish that I could see you, but hello and thank you so much for being here. This presentation, my understanding is that it will be available following this in-person meeting as well. So at any time, if you want to look back at it, feel free to do so. My presentation is titled Putting Comfort Back in Comfort Care. What is hospice? My name is Jennifer Campbell. I go by Jen. I am the medical social worker with ProMedica Hospice, formerly Heartland Hospice. Rather than try to sell you on a specific hospice today, I just want to go over what hospice actually is and what it does for our community and the people who use hospice services. The reason I chose this title is because I think hospice, the word itself, is very scary for people to hear. And I think there's a lot of misconceptions that really happen when you talk about hospice. So I hope to dispel some of the myths about hospice today and try to make it a little more comfortable of a topic for everyone. So over the course of today's presentation, which will probably last about an hour, I'm going to explain the hospice program to you, explore some of the goals that are related to hospice care, the core facts and services that hospices provide. I will be coming from my own experience working with ProMedica Heartland Hospice, but a lot of them are really similar across the board. So, certainly every hospice is a little bit different, but this will give you kind of a general overview. We're going to go over some myths of hospice. I will let you guys have an opportunity to share kind of what you think hospice might look like or some of the things that you've heard, and we'll talk about whether or not those are true, at least from what we've seen. We'll go over some statistics about hospice, and we'll figure out, maybe hospice is right. It is the right time for you or your loved ones. So we'll go over what that looks like and just try to make this a little less scary. I know the people who are coming today, maybe you're just interested in hospice, or maybe you're wondering if it is the right time for you or for your loved one to sign up. And my hope today is that you leave here with a sense of peace, that you know what's right for you, and that you're able to have a better understanding of what it might look like to select hospice services. The philosophy of hospice is all about comfort care, and we talk about that a lot, but what actually is comfort care? There is a difference between palliative care and hospice. So palliative care, people can still be seeking treatments that can prolong life and cure disease. Once people select hospice, it is a focus on comfort, basically quality of life. But it is for the people who basically have stopped trying to prolong life by seeking out a cure to a disease. So for example, chemotherapy, if somebody has cancer, or aggressive treatments that are designed to fix the problem. Comfort care is designed with just that in mind. It's to keep people comfortable. It's also to give them quality rather than quantity of life. Certainly we want them around for as long as they're able to be around, but it's about making the time that they have with us more meaningful, rather than spending days and days, day in, day out at dialysis treatments or this and that and the other thing. It's really about, how do we have you spend time with your family? How can you take the time that you have left and make it the most meaningful time that you can have? So we do use medications, and we do still have some treatments. People will still have treatments that keep them comfortable. We have someone who uses thoracentesis, which drains fluids from the lungs. It is not intended to cure disease, but that is a treatment that keeps this person comfortable. And so we've arranged it where he can still have that and can be using that procedure so that he can have the best quality of life. So it's not like we don't say yes to any treatment ever, but it's just the goal of the care is to keep the person comfortable rather than to cure the illness. It is also a benefit of Medicare. So the Medicare program looked at the numbers, the dollars that were used as people were approaching the end of life, and they saw that there was this huge trend of people going to the ER and rushing off to urgent care, and they were spending so much money in the last few months of a person's life because there wasn't a program. Hospice was designed as a Medicare benefit so that people could get care right in their homes, so that people could get care that comes to them. And so there wasn't this, huge turnaround in the ED, the emergency department. So it was established as a Medicare program. We have what's called a terminal condition, and that is the admitting diagnosis that a patient comes on with. So it might be, a heart disease, cancer, kidney problems, breathing disorders. We have tons of different diagnoses, but that terminal condition is really important in Medicare language because that is the reason that a person is on hospice, and everything that's related to that terminal condition is covered by the hospice program. So that might be the medical supplies that you need for that. It might be the nursing care that comes with that, the aid care that comes with that, the social worker, spiritual care, basically the whole team, the medical supplies, and then any treatments that are used to help with that condition. All of the things that are related to that admitting diagnosis are all covered by the program. The generic kind of wording for hospice is that if that disease, that terminal condition, were to proceed at its normal course of pace, this person is expected to have 6 months or less to live. Now, none of us get to play God. And so we've had patients on our service for hours or days. We've also had patients on our service for months and even years. We've had someone on service for 2 or 3 years. So, even though this is kind of the, if the disease took its normal course, it certainly doesn't mean, you're signing a blank check for someone's kind of expiration date, if you will. The care includes regular nursing care, hospice aid, social workers, spiritual care, and we have a lot of other services that we provide as well. We do have medication that gets provided, all of it covered by hospice. If there's anything that isn't covered by hospice, it doesn't mean that your other insurance, the insurance that you have or had before hospice won't cover it. It just means that it's not a part of the Medicare covered hospice program. And we also provide on-call support, 27 hours a day, all of those hours, 24 hours a day, 7 days a week. And so, we want to give you the opportunity to feel comfortable. If there's an emergency that happens at home, you can call us. We joke that we become your new 911. So it's, you can get answers immediately from, we have a nurse that's on call 24/7, and they can, they'll make a visit, even if it's 3 in the morning. We have a support services person who's always on call too. So, if you call and it's just an overwhelming day, an overwhelming time, it's not just business hours, it's 24/7. One thing I just want to clarify, some people think that electing hospice services means having an in-home 24/7 care provider, and that isn't something that's covered by the hospice program. We can certainly make referrals to having, in-home caregivers. That is a private pay situation, so that gets a little confusing. But our nursing visits are typically, once a week, maybe twice a week. As a person gets sicker, they might be every day. But those visits are intended to, balance medication, make sure that the person's not in pain, make sure that the person's really feeling comfortable. It isn't necessarily to be intrusive and sit with the family all day and all night. We want to give you your family time and empower the caregivers, the family members, to become, the person that's taking care of their loved one. So it isn't what we call a sitting service. I can only speak from my experience. I worked with ProMedica Heartland Hospice. So we provide volunteers, massage therapy. Those are some of the other disciplines that are included. I don't think every hospice has those, so I'll mention this a few different times, but shop around, shop for the best program that's right for you. There's 3 hospices that I know of that serve our area. So, you know, my perspective, of course, is based on my own experience. If you're not seeing what you want to be seeing, certainly look for what might be right for you. We offer respite, Medicare offers respite, which is an opportunity for a person to go to a Medicare facility, so like a skilled nursing facility, for 5 nights, and that's paid for by Medicare. So it's a great opportunity for caregivers, not just who are, you know, maybe out of town for a few days, but maybe who just need a break. You know, we get some caregivers who are like, this is a lot. And there's actually been some articles published recently where people want a good death at home, quote unquote, but they, you know, this hospice it can be really tough because it does empower the family to be the caregivers. And not everyone was necessarily signing up for that when they, you know, when their loved one came down with this illness. So respite provides an opportunity for patients to be able to be taken care of in a skilled facility without, you know, while also giving their loved ones a break and giving them a chance to have some time and some space and get things figured out. We also coordinate with facility placement. So for the people who, you know, it can be overwhelming. My patients come to me and they're like, I don't even know where to go. I don't necessarily want to stay at home, but I don't know where to turn to, and I don't know if I qualify for assisted living or if I should be in a skilled facility. What do I do? So part of our team as well works with facility placement. So where should you be? Where has availability? What does your financial state look like? And then we can also coordinate with the financial piece. Each facility tends to have their own kind of social worker that does sort of that financial piece to stuff too. So we can coordinate with them so that it's not necessarily directly coming out of your pocket. Maybe you can look into getting Medicaid and that whole process. The facility staff are really great about knowing what their facility needs. So we do a lot of coordination for facility placement. We also do bereavement support. Our bereavement program lasts 13 months. And so we follow up with a person shortly after the patient passes. We also do a 2-week call, about a month or 6-week call, and then pretty much quarterly after that to make sure that a person's doing okay. This is really helpful because in a calendar year, you have holidays, you have what we call anniversary, the anniversary of a person's death. Maybe anniversary dates are other things, birthdays or important dates for this family that, mom isn't around for anymore. Or, my brother was always the person who, hung the piñata during this event, and that doesn't happen anymore. So our bereavement program follows a patient's family after the patient passes for 13 months. We have financial assistance, and we also have funeral planning. So those are some of my roles, so I know them pretty well. But we try to work with the family so that, whether you've thought about your funeral in depth or you've never even thought about it, we want to help the person and the patient and the family be more comfortable with what is this going to look like? What is my timeline here on earth, and what funeral home would I like to work with, and how do we want to go about that? The same is true for financial assistance. Like I said, we do a lot more contacting with various, facility placements that can then help with their side of things. But it is intended to be, are you safe where you are, and do you have the needs met that you need to have? We have lots of connections to community resources. I just made a referral today over to Michael's Place, who specializes over in grief as well. We have lots of different community partners that we work with, and I'm really thankful that we have those opportunities. The last thing we have, and I don't know if the other hospices have this, but something that I love about ProMedica Heartland, we have the Memorial Fund. And what that is a fund for patients and their families. They can, donate to that. Anyone can donate to it, but it gets used for other patients in the program. So it's really cool because we have people who pass away with us and say, like, what can I do? How can I kind of forward this, pay it forward? And so this opportunity allows for people to have money support, financial support from other patients and their families. So it's one of my favorite things that we do. It's a pretty cool program. So, interactive time. What are some of the assumptions that you have about hospice? What are some of the things that you believe to be true about hospice care?
Other questions? So let's say they're on your service, but then for whatever reason, a blessing, a miracle, whatever, they start doing tremendously better. And maybe is there a point ever where you say, you know, we think it's not appropriate for you to feel this now, you know, we will revisit it at a later time, or something like that. Does that ever happen?
It sure does, yeah. So the question in the audience was, if we had a person that was on our service, but then by whatever reason, they are doing better, do they come off our service? How does that work? So yes, I will certainly go over that in one of my questions, but we do have what we call live discharges. Maybe that's a person who moves out of our service territory. We have less snowbirds, right? So they go back to their warm place where they go and they get connected with a hospice down there. We also have some people who do recover during this COVID time. We had a lot of people who had COVID, were kind of, you know, we were pretty close to maybe this is, you know, their last week with us. And then by whatever, you know, grace happened, they did recover. And so there have been patients that we've discharged. I'll go over the specifics of that in just a little bit. Other questions, assumptions that you have?
How are volunteers used? Because I know Munson is a hospice system that is self-enclosed.
Absolutely.
Hospice of Michigan is a different way, and they have people that regularly visit people. So how, based on the organization, how would you learn more about what you would like?
Absolutely. The question in the audience was, how are volunteers utilized? And I think you're right. The answer is, I think it depends on the hospice. For us, for ProMedica, we use volunteers, we use community members in a variety of ways. We just started doing something that we call a pinning ceremony, where we take veterans who, you know, were part of the military, of course, and we will do a pinning of other veterans that were in the service that are on hospice services. We have people who help with bereavement support. We have people who help with maybe mailings, Christmas cards, you know, things like that that are intended for community outreach. We have people who, you know, help to maybe be a volunteer in the office, and they're stuffing envelopes with the information that I'm presenting today, you know, things like that. And then we have patients that are people that do go see patients, and we have them that sit with them regularly, if it's in a facility or in their home. And, you know, maybe they visit a couple of times a month, maybe they visit, you know, once a month, maybe it's, you know, it really depends on the patient's needs. We had someone who was doing haircuts for a while. So really it's, you know, whoever wants to partner with us, we want to take you in, we want to find a role from you. I think we were up, I might get the numbers wrong. I think we were up to having like somewhere between 40 and 50 volunteers in the summer months. So certainly, you know, if you're interested in volunteering, I only know my experience, but certainly work with the hospice that you want to figure out, Munson Hospice, Hospice of Michigan, or certainly call us at ProMedica and we can hook you up.
How do you find out what the differences are between the hospices? Because you seem to have 3 different organizations.
Yeah, how do you find out the differences between the hospices? I think, you know, I talk about shop around. I think the real answer is, you know, call them and see what volunteer opportunities am I, you know, can I get involved with here? Or if it's on the patient side, do you offer this thing? You know, what are you looking for out of your hospice? My presentation today should give an overview of like what's included in hospice in general. If you're really looking for massage therapy, call them. You know, do you offer massage therapy with your hospice patients? Is this something that you provide? Those specific questions, I think, will be the chart factor of who offers what in our area.
Once you are with, oh, I'm sorry.
I just wondered, once you enter hospice, do you have to give up all your regular doctors?
I'm so glad you asked that. So yeah, that's one of my points as well. The question was, if you enter hospice, do you have to give up all of your regular doctors? So I will answer that. The short answer is we want you to keep an attending physician, someone who knows you the best, typically is like your primary care physician. But then yes, rather than having a cancer doctor and a bone doctor and a joint doctor and a this doctor and a, you know, we do like, you can, instead of going to appointments every day of your life, you know, go ahead and let some of those go. Keep your, you know, primary physician, someone who knows you the best, and then they tag team with our doctors so that you can receive kind of that partnered care. Other questions? Any questions on Zoom?
If you're involved in one hospice, can you change?
If you're involved in one hospice, can you change? Absolutely. Yeah. Yep. We have some people who certainly, you know, it's not always based on service area, but sometimes, if they move to a spot that our service territory goes all the way up to like East Jordan area, Eastport, and then, almost to Charlevoix, and then comes all the way down to Lake Manton. It goes from Frankfurt all the way out to almost Grayling. So we cover a pretty big service territory, but certainly, if someone moves out of that service territory, they can switch hospices. If someone's not happy with the care they're receiving, they can absolutely switch hospices. So you are not locked into any one hospice system. And I think that's really important to note, especially, Munson runs the hospitals up here. So certainly I think, it would make sense to me. I haven't been in this situation, but it would make sense to me that they push their hospice. Know that you have options and you get to choose where you'd like to go. Yeah. Okay. Any other thoughts, questions? I'm so glad you guys hit on some of these. This is fantastic. Okay, myths of hospice. The first one is that it's just for people on their last breath, just for people who are at the very, very end of your life. I like to tell all of my patients who are getting information visits that the philosophy is really changing. Wouldn't it be nice to meet the people who are taking care of you for the rest of your life before it's the rest of your life? So as long as a person is eligible, and we kind of have a nurse that goes out and checks for eligibility. I joke around and I say, if you're ever not eligible for hospice, that's not a bad thing, right? I have some people who are like, oh, I wasn't eligible. I'm like, that's okay. That's all right. But yeah, certainly. So it isn't just for people who are on their last breath. Like I said, it technically is the physician certifies that a patient has 6 months or less to live. But research shows that hospice gets started way too late in most cases. And that will be kind of one of my other points too, but you can ask your physician about hospice. You can call hospice directly and ask about eligibility. So certainly, the average length of stay in 2019 was 92.6 days. So it's about 3 months. It would be wonderful if we could start it even sooner and get to know our patient and our family and their loved ones and who are your kids and who are your grandkids. And, can we provide you the support so that you see my face and you're like, oh yeah, that's the social worker. So that when, this person is maybe on their last breath and I hold their hand and I say, hey, it's Jen with Heartland. And I just wanted to say I'm here and I want you to know that you are not alone. If that name doesn't mean anything to a family, it's not going to be nearly as impactful. So certainly we'd love to start hospice services as soon as you think someone might be eligible. Another myth is that caregivers give morphine to end a person's life. So the morphine doses that we use tend to be very small, depending on a person's needs, right? We have some people who have, long history of chronic pain, and so their tolerance is a lot higher than somebody else. But we balance those based on a person's need. And morphine does two things. It helps with pain, and it also opens up the airway and helps with breathing. So it can be really beneficial. Once a person has a dose of morphine, it does not mean that they're going to die. We talk about how in our little bottle of some of those, if somebody were to take the whole thing, they'd sleep really well, but they would still, wake up the next day. So certainly morphine does not cause death. It does reduce pain, and in some cases, it does allow for a person's body to relax enough that it is able to their body is able to end its life, right? So it certainly is used for pain control and to open up the airway for breathing. Hospice requires a do not resuscitate order. That is one of the myths of hospice. I think this is one of your, how do you know which hospice is right for you? Some of them do require that, right? So some of them do require you have to have a DNR on file in order to be a part of our services. Our hospice, Permanent, we don't have that. We have patients who are still at full code. So shop around, figure out what is best for you, but that is not necessarily a 100% across the board. You need a DNR to be on hospice. Myth, you have to get rid of all your other doctors so that you can be on hospice. Like I said, we encourage you to have one doctor. Your one doctor, usually your primary physician, will follow you. They know you, they've seen you. They know who you are, they know what conditions you have. Our hospice medical director will then tag team with that physician so that we have someone who knows you really well and someone who knows hospice really well. And those two tag team, they ask each other about orders, they see what you need to be done so that you can have the best care personalized for you and also meeting the goals of hospice so that you can be comfortable, so that you can have that increased quality of life that we talked about. All right. This one, I have to have Medicare or be over 65 to qualify for hospice. That's not true. Some other insurance plans also provide hospice benefits. We have people with the insurance that they got through their workplace that will cover hospice benefits. Our team can really help you figure that out. So if you were to contact us and be like, hey, I have priority health and I don't know if I have hospice benefits, what does this look like? Our team is super great about digging into that and figuring out what benefits you actually have. If someone did have to pay out of pocket, our team will also arrange what that looks like for you so that it wouldn't be the full cost, for instance, that we might have to charge Medicare, things like that. Not my job, but someone in our office would be very, very knowledgeable about that, I promise. Okay, continue this. You're never allowed to go to the ER if you're on hospice. That's not true. Please go to the hospital if you have a life-threatening emergency, like you cut off your thumb, which is something that I'm talking about from experience. So if that happens, certainly go to the ER. But we do become kind of your new 911. So we have a lot of people that say, I can't breathe. What happens? And we say, okay, well, have you tried giving this person a little bit of morphine, right? Enough to open up that airway and do that, that's why we have that on-call 24/7 support, because instead of rushing to the ER every time something little happens, having nursing care that can just answer your questions over the phone helps out the Medicare program by reducing the number of ER visits, and also helps the patient by getting immediate answers instead of waiting in the ER for 4 hours. You have to go to a hospice house to be on hospice services. That's not true. So this is another thing where you can shop around. We don't have a hospice house. Hospice house, I'm still a little fuzzy on the details, but my understanding of a hospice house is kind of the last few hours or days of a patient's life where they can go there to die. That is a different kind of, I don't want to say facility, but that's a different avenue than we have. We meet patients in their homes or in facilities, assisted living, skilled nursing facilities, and we, take care of them throughout the end of their life. A hospice house, the only one that does exist is through Munson, and I don't know a lot about it. But again, this is where if you want to shop around and figure out what's best for you, if you're really looking for a hospice house, one, figure out what exactly that is that you're looking for, and two, make sure that the one that you want to go with meets your needs. Okay, this is another myth, a big one, a really big one. Your doctor is supposed to suggest hospice to you. So research is crazy on this. There's been a lot of new studies that suggest that doctors who have conversations with their patients sooner have a longer time in hospice and have better outcomes, quality of life, and reduced depression, including major depressive disorder for bereaved caregivers. So in other words, the sooner the hospice is started, less depression happens. So more hospice means less depression. That being said, not all doctors understand that the philosophy is changing and that we do want to meet people kind of sooner to the end of life. So, we do encourage physicians, please, if you think a person might be eligible for hospice, please call us. But if your doctor's not bringing it up, bring it up to them. Say, could this be a case where we're kind of done with this treatment? We're done with this is a lot. Could we maybe start hospice services? And if you're, we do need a referral from a physician, but you can certainly call us directly and ask us about what your loved one is experiencing too. Okay, and then the last myth is that all hospices are the same. So this is also not true. There's 4,840 hospices across the US. Some are for-profit, some are nonprofit, some are governmental agencies. ProMedica Heartland is a nonprofit hospice. And so we, again, shop around for what you're looking for, make sure that it meets your needs. All right, facts and figures. I'm a nerd, I'm a data girl. I did my my master's in social work at the University of Michigan for social policy. So I'm all about policy and data and research, and I'm a nerd. So a couple of facts and figures for you. 1.61 million Medicare beneficiaries who died were enrolled for 1 day or more in 2019, which is 51% of all Medicare recipients. So over half of Medicare recipients were involved in hospice for at least a day in 2019. That's the latest data that we have available. That's from the National Hospice and Palliative Care Organization, and that just came out in October. We have, as of 2019, $20.9 billion Medicare dollars were spent for hospice, which if you were to look at the amount that was spent for the ER and things like that, it has been drastically reduced since hospice started. So it is an effective program, it is working. Primary diagnoses often include Alzheimer's, dementia, Parkinson's, heart disease, cancer, respiratory disease, stroke, kidney disease, and more. There's lots and lots of admitting diagnoses out there. Family caregivers who have hospice too late are 700% more likely to experience major depressive disorder. And depression decreases the longer a person is in hospice. There's research that suggests that if a person is involved with hospice, they will live on average 2.7 months longer than someone who doesn't have hospice services. And often that's because hospice services were started instead of these aggressive treatments, which then can build up these negative emotions in caregivers and can lead to some of this complicated grief. So more hospice, less depression. So here's my other fun fact that I spoiled for myself, but patients who have hospice often live 2.7 months longer than those with aggressive treatments. This is, like I said, none of us get to play God, none of us get to, well, if I start hospice today, then I'm buying myself 2.5 months. It doesn't work like that, but we do find that the sooner a patient starts hospice services rather than aggressive treatments, their quality of life is improved. And the same way that sometimes if we take a person who's in a facility and they get to go home, they almost perk back up for a minute and they're like with their family again, and you see these waves of energy that you just weren't seeing in a facility. Sometimes people just like take to heart that they get to experience more quality of life and they get to be with their family. Even if they're in a facility, the difference between being hooked up to monitors and IVs and fluids and things, constant monitors and things like that versus just you're there and you get people that take care of you. And if you want to eat ice cream for every meal, you go for it, man, because you earned it. So that's kind of the difference between hospice versus those aggressive treatments. Hospice patients also have lower suicide rates. So the data that suggests that for a longer time that a person is involved with hospice, suicide rates also decrease. There's also, not to get down a rabbit hole, which I've gone down before, but in Oregon, where physician-assisted suicide is legal, patients who found out more information about hospice were actually less likely to go through with that and to end their life, even though they could, and it was physician-assisted. So hospice can really support patients who are on the fence with what quality of life really means for them. There was a question in the audience.
What treatments need to be stopped when you enter hospice?
Yeah, what treatments need to be stopped when you enter hospice? So I was kind of explaining, we have someone, we have different patients who still have, services that drain some fluid from their lungs, or maybe they get a blood transfusion. It will really depend what that hospice is willing to provide versus not. So this is another case, shop around to figure out what's right for you. We have a team, so anytime I meet with a family and they're like, okay, but we're doing this and it's really helping. And it's not like we're trying to, cure disease, but it makes this guy feel better. Can we keep doing it? So I call over my supervisor and often they'll have a conversation with what that looks like and, can we continue that treatment or not? So that's another case where talk to the hospice provider to make sure that you are getting what you need and what you're able to get.
So you mean no more curing?
No more curing. So the philosophy,
Chemo,
exactly.
things like that.
Yep. So curative treatments that are intended to prolong life and cure disease are often stopped with hospice unless they are for comfort specifically. Yeah.
Do you have any transplant patients in? Because my understanding is like, stop taking your anti-rejection meds, you'll die in about 6 months.
Sure.
So that's a quandary because, I think they keep them on them right till their lungs are just about done.
Sure.
So that's a big question.
Sure. The question is, do we have any transplant patients that are on the service who, if they stop taking their anti-rejection medications, will pass in 6 months or less? And, they were often kept on those medications until the very end of life. I wish I had the specifics on that. This is where I play the social worker card. But certainly, if you were to call over to our office, our staff could certainly help you with that and give you a better understanding of what we cover and what we're not able to.
So
I do know that
their
we-
Their lungs are continuing to decline anyway.
Yeah.
But they still have to take all these meds.
Absolutely,
It's like, and the
Yeah.
transplant centers are like, keep taking them,
for sure.
you know,
So,
it's like, ugh.
yeah, so the philosophy, with some cancer centers is, even though your lungs are declining, please still keep taking the meds, it will still help you out. So,
And then they say you can't get hospice because of it.
sure.
It's crazy, man.
Yeah, I would say talk to our staff that can help you, figure out what you can and can't do. I do know kind of two things. One, I know that we pay for some crazy expensive medications. Couldn't tell you what they are or what they do, but because they are for comfort. The other thing that I know that we do is, our doctor will work, like I said, with the attending physician to really pare down medications so that a person's only taking what they need and what's actually helping them. So I don't know if that gives you a better understanding, but call the office, call the staff of whatever hospice you're interested in and ask them that question. If you see in this figure, it has days of care, and as a person is in hospice for longer, you see that these rates of depression, suicidality go down, so that it's better for caregivers who take care of them as well as for the patients. That being said, we still have had 10% of people who were only in hospice for 2 days or less. So, and we only have we have 10% of patients who are enrolled for more than 266 days. So certainly that middle range, of a year or less is where most patients fall. If you are thinking you might be eligible or someone you love might be eligible, give us a call. The worst thing that happens with that is we come out, we have a conversation with hospice and we say, well, actually you're too healthy for us right now, but we'll check back in with you in a month. Okay? So my encouragements to you, please start hospice early. Earlier hospice conversations increase quality of life. It's just as simple as that. It really is. It lengthens survival, it can lower costs, and it improves satisfaction with healthcare. Eligibility might look like weight loss, recent falls, eating less, wanting to stop treatments to fight disease like chemo, right? We have patients that, maybe they haven't necessarily had all of those things, but they've had, a CVA or a TIA or a little stroke or something. And it's really changed what a person needs. Now they need help with all of their activities of daily living, bathing and grooming and showering and toileting and eating and other things. And, when they're at that point where they need help with those things, maybe it's time. Maybe it's time to even just see if hospice is right for you. Like I said, if you're not eligible for hospice, that's okay. It's all right. We'll check back in with you and we can see if you're eligible in a month, or maybe there's some other event. But now we've met you, we've met your family, we know who you are. And so even though you aren't necessarily in the our patient for hospice, you still are connected with someone who's in your community. Also, talk to your doctor about hospice. If you're ready to stop aggressive treatments, if your person, your patient is saying to you, man, I'm done. This chemo it's getting to me. Okay, my dad went through hospice, and that was a really tough thing for our family. He went to have a surgery that was intended to take out some of his teeth. He had tongue and throat cancer, was intended to remove some of his teeth and part of his tongue, and wound up removing his entire lower jaw. His mouth hung open for the rest of the 8 months that he was with us. He never ate, drank, or talked ever again. So my connection with hospice is a very personal one, as well as my work. Those conversations with hospice are really important, because when a person is sick of fighting that fight, to honor their wishes is kind of a wonderful gift, even though you might not be ready to lose your person. Patients who don't have end-of-life discussions with their physician have more intense care in their last weeks of life, leading to recurring reduced patient quality of life and higher risk for major depressive disorder and bereaved caregivers. The research says that if a person was having all of these aggressive treatments and they pass, their caregivers are going to have more guilt, more shame, and more complicated grief than if they were to die with comfort care, so that they were getting this focus on quality of life. Caregiving can be a lot of work on families, And that's just a blanket statement. That comes from an article that was published that says people want this good death at home, but it's not exactly all it's cracked up to be because hospice is still a lot of work. So our role with that is to empower families so that they can give these drugs, feel more comfortable, call us when something's going on, be with their loved one that they are seeing decline, but in like a still feeling okay and everyone's on the same page kind of a way. We have patients who, don't start hospice early, and so they kind of have this very sudden jolting, everything is happening all at once. So the way I see it, if you can get hospice services on board, you're doing yourself and your caregivers and your patient a service by, getting to know this team that's going to take care of you for the rest of their life. I don't know that my fact about people who recovered was actually in there. So here's my extra tidbit for you. We have had patients that are what we call live discharge. They got healthy, and I joke around with people at sign-ons. I do a lot of sign-ons and meet with families, and I sit down, I do the same kind of presentation with them. And I say, man, if you start running marathons, we're gonna have to talk. This is not everyone kind of goes down that route. I think the statistics are somewhere in the 90% range of the people who go through with hospice through the end of their life. But there's still this small percentage of patients who do recover, or they move out of the service territory, end up getting connected with another hospice, et cetera, et cetera. So shop around, find the hospice that works best for you. And if your person doesn't start eligible or doesn't end eligible, that's okay. It's a good thing. Yeah, a question in the chat.
What does a hospice nurse do when he or she comes into it?
That's a great question. So the question is, what does a hospice nurse do when they come into a long-term care facility? So when a hospice nurse comes into a long-term care facility, typically the facilities are really excited because it means extra eyes on that patient. As we all know, the world right now is very strapped for resources. And so to have someone who will come visit you every week or twice a week, or if it's kind of a dire situation every day, that can be another resource for these long-term care facilities to call in and to say, hey, this is happening, Mr. Jones over here is not, is gasping for air, what do we do? Or, it provides some extra resources for the facility staff. We are trained in hospice. We are trained in end-of-life care. I say that the nurses are very trained in end-of-life care, and the medications that can help with these symptoms that a person is facing, really they become, like I said, the new 911 for the long-term care staff. So it's extra eyes on the patient. We have aid services that come in. They help with some of those, TLC things, giving baths, giving showers, and then, balancing medications, making sure that things are good. So it's extra eyes on the patient. It's support for the family. So part of my role there is also, calling them. I see Mr. Jones in the facility, and then I call his daughter and say, hey, how are you doing? Because this is a lot all at once. And how are you coping? So, there's, I guess, the benefit to a person who's in a long-term care facility is that it's not just one person being like, oh, yeah, there she is. It's really true care that's designed to work with a patient to see what they need, to see what's not working for them anymore. Hey, they're taking this vitamin, it's not doing anything for them. Can we just get rid of it? So it's one less thing to bug them about in the middle of the night and have it swallow. To really pare down what is working for this person, and then to lay extra eyes on their family too. Any other questions?
What is, I don't know if you're able to answer this, or if you know, but to your knowledge, what is the youngest patient you've had on your hospice service?
Yeah, what's the youngest patient we've had on our services? I wish I had that data right in front of me. If you're interested, I'd be happy to ask, and I can get back to you on that. I know that we've certainly had people in their 50s. We have certainly also had people in their 40s. The youngest person that I've worked with had some teenage children. I want to say like late 30s.
Wow.
So there are various diseases out there that don't pick an age. So ALS tends to be one of them. If you want more information, please call the hospice that's right for you. I have listed up here the ProMedica hospice information. This is not to sell you on ProMedica, but to give you a place that you can call that can answer your questions for you. So our number is 231-935-3089. You can call us. You can ask for me if you want to ask me specifics. If you want more nursing questions, you can ask someone who's not me and they might know the answer to that. You also, feel free to email me if you want to ask me questions directly. We also have a website that will answer a lot of your questions. Like I said, we were formerly Heartland Hospice, so our office is right in Copper Ridge. We just changed our name, corporate mergers and all of that, but our care hasn't changed. So our color scrubs are now neon green instead of blue. That's really the biggest difference I can see. So, reach out to us. But there's other hospices in the area too. And I've listed Hospice of Munson, Hospice of Michigan, and also Munson as well. So feel free to call the one that is best for you. Find us on the web, Google it, figure out, if there's specific services that you want to see if your hospice will offer you, figure out what those are that are right for you, and then ask if that hospice provides it. You have the right to shop around. You have the right to figure out what is going to work for you. Okay. No matter which hospice you choose, just consider starting it. Consider asking about eligibility for your loved one. Consider seeing if it's right for you. Maybe it's not the right time right now, but having those conversations early straight up increases quality of life. Okay. Here's some references because, I'm a nerd, so I cite my sources. And the last slide is just a thank you slide. Thank you for being here. I will take questions if there are any more questions in the audience on Zoom or here in person. Any other things that you need answered? Thank you so much for being here today. Please contact me if you have any questions. If you want to ask about your loved one specifically, I'm happy to talk to you after this. And I'm happy also to give you to my bosses and the people who kind of handle the referral sources and maybe get the process rolling for you. Okay. Thank you so much, you guys. You have a great day.
Thank
Take
you.
care. Thank you.
Awesome.